Hello, everyone, and welcome to today's webinar, Best Practices and Strategies to Successfully Navigate Healthcare. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I would now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations, on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you to everybody for joining us today. As I was reflecting on this webinar, I just got very excited because we enjoyed hosting these webinars, and we enjoyed the interaction with people who choose to register and participate. So as Alex mentioned, feel free to submit your questions. Again, all of these slides will be shared with you. If you've ever heard me speak before, I do cover a lot of content, and I apologize ahead of time because I tend to talk fast, but I will try to manage my cadence and slow down a little bit. But a lot of this is exciting to me. Navigating this successfully is exciting to me. It's been what I've been doing for the past 20 years. And so I look forward to our discussion today. We will have multiple sessions coming up every month on real strategic topics for each of you to not only successfully navigate the future of healthcare, but really focus in to drive more revenue, drive more profitability, improve care, improve quality, everything that improves your bottom line. So that's really what our company is focused on. That's what our educational and webinars are all focused on. And anything in between these webinars, any questions that you guys have, feel free to reach out to us. We're here. I love to serve. I love to help. We love to think strategically with people and help in every way. So do feel free to engage us. Use this opportunity today as a level set, and then kind of go from there. And I'm going to cover a lot of ground today. I'm not just going to talk about macro or MIPS or anything like that. This one, for me, is exciting because we get to really drill down into strategy, not so much the bits and bytes of MIPS or quality reporting or MACRA or any other policy driving healthcare, which I have to do that a lot. And I host a lot of webinars on those topics. You can go back to our website. We did webinars all the last 3 months, specifically on MIPS and quality reporting, and even by specialty. So orthopedics, radiology, cardiology, OBGYN, general surgery, all these different specialties we have up there. And we even give coding best practices to help you drive additional revenue. So those are all available. But today's focus really is on strategy and best practices. So this is a great topic, a fun topic for me. So starting at a high level, I'm going to give you a little bit of predictions, spend a lot of time doing public speaking on this and a lot of thought leadership writing. And also have we're very fortunate to be somewhat close to the incoming Secretary for Health and Human Services. I'm from Georgia, originally from Boston, but live in Atlanta now. But I've been friends with Tom Price for about 20 years now, and actually had a little business adventure with him many years ago. He's just an overall a great guy. He's an orthopedic surgeon. I think he's going to be fantastic for healthcare. He's going to make sure that providers receive the best programs possible, and I'll touch on that a little bit for sure coming up. But some real high-level items, and we're going to drill deeper and deeper as we go through. But very importantly is to keep an eye on the ACA repeal and replace is coming out, understand how it could affect you. And because there are going to be effects. Obviously, these changes are not all going to occur in 2017. But I'm thinking more long term. I call it long ball, playing long ball, thinking 2 years, 3 years, 4 years down the road to make sure that you're headed in the right direction. But there's aspects to ACA which are going to affect everybody, potentially in 2017, but certainly in 2018 and 2019. But also consumerism. And I think everybody's heard that before, certainly if you've ever heard me speak before. But consumerism is really where patients are consuming their health care and they're becoming true consumers. And I say that, I mean they're paying more of their pie in generality. They're paying more of their health care expenses than ever before. They're making more informed decisions than ever before. They're talking with their wallet more than ever before. So it's just to understand, what does this mean for you? How does it affect patient volumes? How does it affect your profitability? How does it affect your healthcare ecosystem on where you send referrals or where you receive referrals? There's lots of aspects to it. The rise of retail clinics have shifted care, but it hasn't affected a lot of people in some regards because we needed more care providers, and now we have them in these retail type settings, urgent care centers. So it's important to look out. Also, the rise of insurance or companies that put on their own clinics or purchase and install their own clinics inside of their organizations. If you have more than 1,000 employees, you look at the numbers, it actually makes sense to put an on-site medical clinic attached to your building or in your community. And even if the company doesn't do that, there's one that we had with 800 employees. We struck up a relationship with a local practice. We didn't own them. We just put together an agreement with them, a working arrangement with them. So our patients for non-emergencies, our employees for non-emergencies would go to that local practice. That was a boon for us. It saved us a lot of money, millions of dollars a year. And it also brought a great strategy to those care providers that we sent, that medical practice that we sent patients to. So you want to think differently. That's kind of what this presentation today is going to be about. I'm going to give you thoughts and ideas to expand upon, and then also maybe inject into your practice or your hospital. And to be honest, that strategy right there goes for a simple hospital that's in a community or even a medical practice. You can establish a relationship with a larger employer. Any employer that's got more than 250 to 350 employees in that region, it could make a lot of sense to do an on-site clinic, or certainly an established relationship with a medical practice that has a multi-specialty group or even a large primary care group. So there's lots of opportunities that I think people should start to explore. I know it's the best practice. I'm in the middle of a lot of those, so I know it's fruitful for everybody involved. It can save a lot of money for companies, and it can bring a lot of money to specific practices that engage those types of strategies. Also, my next bullet is expect stability and support for health IT use, but also even more focus, and this is by the new secretary, by Tom Price. He's going to focus a lot more on provider usability and ease of reporting to make sure these EHRs that we all have can be functional and usable for their investment that everybody's already made in them. And certainly the administration, including the White House and so forth, they want their ROI on the $34 billion that's already been injected into the use, the purchase and the use of EHR technology, certified EHR technology. So Congress is going to demand ROI for that. So in that, you're going to see more demands on the EHR providers to make them more usable, more functional, and whatever programs we create at a CMS and even in the private sector, in the commercial sector, that it's easier reporting, more comprehensive for providers, less work on providers' shoulders, and that we leverage innovation, that we leverage technology better. And that yearn will never stop. We need to always make sure that the investments that we've already made, the technology and the innovation that are at our fingertips gets better. And we all are committed to that, I promise you. On the regulatory-wise, legislative-wise, from the EHR provider world, and certainly from the care provider world. And I promise you, Tom Price personally takes that to heart. and that's who will run a lot of this from a rule standpoint in HHS. So I think it's important to understand that. So even more help is on the way, but health IT is not going anywhere. We're not going back to manila envelopes and for manila folders for patient charts. We have to make sure that we're leveraging health IT. And as a mantra that I've had in the last year or so, I don't think people necessarily need to buy more health IT. I truly believe in my heart they need to leverage. If they bought a top 10 or a top 20 EHR that's in the market, and they successfully deployed it, and they spent time learning it and training on it and customizing to the workflow, that they could and should be wildly successful with how healthcare is evolving. But it's not that easy. And I've lived and breathed this again for 20 years. I've been in this industry and specifically doing that. So now with what we're doing at iHealth, it's very important to leverage the innovation that you've already invested in, customize it to your workflow, ensure it supports your strategic objectives. That's why you're here today in this call, in this webinar. But you're going to get a lot more help coming from that direction. Also, if you've ever heard me speak before, certainly in the last 6 to 9 months, very important to improve revenue and cash flow, and certainly as new payment and care provider and care delivery models are emerging. So what I mean by this is you need to focus and ensure that you get paid for every dollar that is out there, every dollar that you have earned. And what I mean by that is billing and collection and responsibilities for payments, managing denials, appeals, and aspects like that. There's so many components to your revenue cycle, and these are shifting as well. And when I say shifting, we have payers today, and their job, no offense to payers on the line, but they don't, their job is to hold on to that cash as much as possible, and they do that. So it's very important that you have your team, or even you co-source with a team that plays the game with the payers. I'm not just talking about CMS, I'm talking about the commercial payers for sure. You got to make sure that you're playing by the rules, and that you're managing your fee schedules, and that you're getting paid for everything that is inside that fee schedule. 30% of contracts are not paid properly to providers, and it's not in their favor, I promise you that. So it's just very important. There's so many aspects to your revenue cycle, and also the shift over to the patient side. There's simple strategies about deploying patient pay technology, or even patient pay strategies at the point of care, at the point of registration. A lot of people still do not collect copays at the time of the appointment, and chasing that $15, $25, $35, $50, $100 afterwards is expensive. So there's some real simple strategies to improve revenue and your cash flow today, but also it's very important that these strategies are integrated into your all payment models that are coming at us. And they're starting now. MIPS, Merit-Based Incentive Payment Program, that program, or anything under the Quality Payment Program, or even inside our states, so near and dear to my heart, not only navigating the federal programs, but also a lot of the state-based programs. And there's lots of opportunities to be wildly successful and increase cash flow and revenue by 5, 10, 15% or more. But you got to keep a close eye on those components. And there's great opportunity to increase that revenue. Also, as you're deploying health IT and using it, make sure you're improving, your care coordination amongst your practice, amongst the care providers, but also potentially throughout your community. We got to make sure that we're capturing more information, and it's not about more clicks. It's something that's near and dear to my heart is really getting in there and optimizing the EHR that you're using to make sure it's capturing the codes and the documentation at the right time. That can reduce clicks, reduce frustration, improve your revenue, improve collections, and even automatically calculate for all these quality programs that are coming out, such as MIPS. It's not hard. They just need to have the expertise. That's why, that's why we founded iHealth. And it's exactly what we do, and we love to help practices within hospitals and health systems. But you got to make sure that you've focused your infrastructure around this. And also that you've fostered an environment that awards and rewards care coordination and improving population health. Your contracts will slowly do that, certainly as you go at risk or take on these different value-based medicines, or value-based care models and reimbursement structures, but also profit sharing amongst partners. So you want to make sure that all of these actions are properly rewarded and looking for efficiencies as well. I'm going to touch on that here in a moment. And also, there's going to be, in the next couple of months, you're going to see more demand, certainly in the next 6 months with some regulation, but the passage of the 21st Century Cures Act is going to demand interoperability and break down silos of information even faster, and even $1 million per episode of where data may be blocked. So we're going to push, we're going to reward interoperability and data sharing amongst practices and amongst hospitals. It's something that's been in the works for many, many years, and it's finally coming to fruition. So now, talking about the changing and shifting landscapes. So one thing that we work on, and this is what we've seen this out there, and obviously you probably have seen this as well, is practices and hospitals expanding their services and expanding their strategies, looking at what can we do to better serve our patients. Your patient demographics could be shifting. So it's just, stay in tune with that. Look at patient visit volumes. Have they stabilized? Have they increased? Have they decreased? And then understand patient access to care. And I mentioned this at the top of our show, but how do patients consume healthcare? How do they engage your practice? How easy is it for them to schedule appointments, to be seen, to have access to their records, to collaborate in their own care? These are all real key strategies and how and where healthcare is shifting. So we just got to make sure that that practice and hospitals are shifting with it. I want to touch on that here in probably my next slide in greater detail. But also, and I talked about this a little bit, the exploration and management of risk-based contracts. I think about 5% of medical practices and physicians have taken some type of risk-based contract in 2016. But it is expected to grow to about 10% in 2017. And the hospital side, it's much greater. But the majority of people listening today are physician practices. And it's just something to keep an eye on, because you're going to want to bring on the expertise or hire the expertise to be able to take these on, understand what it means for your practice, make sure what it means for your caseload and your patient base, because it's a great opportunity to increase and improve revenue fairly quickly. But also, if it's not managed appropriately, it could bring you off by 10, 15, 20% or more. So it's just something to keep an eye on. But this is where healthcare is shifting. It's getting away from, everybody knows, away from fee for service, certainly over the next 4 to 5 years, starting in 2017. And also, there's a pendulum here of physician practices selling and going into hospitals, into health systems. And now I've seen the swing to come back, whereas a lot of them, and it's for 2 reasons. A, the good ones didn't want, or there's 3 reasons. Some stay, which is fine, but if they come back out, it's usually for 2 reasons. And then number 1 is red tape, bureaucracy, and they're more independent thinkers, and or they saw more opportunity. So they decided to split off, and they bring a few partners with them. And this is what I'm a part of in a lot of communities across the country. And they want to start their own medical practice, maybe a 6-doctor, 10-doctor, 12-doctor multi-specialty group. That's becoming fairly common. They sold the practice, they actually made a little bit of money, went to work for the hospital for 2 years. In some cases, they brokered these great agreements to go back on their own with the hospital. But they're now independent again. That's one of the strategies that I've been part of. The other one that I hear about is where the doctors were not high performers. They were high utilizers of services. They were very expensive for the hospital. In that case, they were let go. They were fired. They were pushed out. It's not about volume. it is, certainly in the hospital environment and readmissions, it's about value. So these are the strategies to keep an eye on. I also see them as opportunities for other ones and for others. The next piece is around something, I call it the underlying multiplier, and how shifting payment models are going to affect you. Not just about CMS and MIPS and MACRA and Quality Payment Program and those specific incentives, but also because a lot more of this will become transparent, certainly with the Medicare programs. We even have the state-based programs and Medicaid programs, but Medicare for sure, they have the Medicare Physician Compare, and I'll link you to the website at the end of this presentation. But a lot of people are moving in this direction to say, hey, we have these programs available, and here are the doctors, here are the care providers participating in them. And sometimes they'll give ratings and grades, or say which part of the program they're participating in. Well, I promise you that is impacting panels, that's impacting referral streams, where patients choose to go, where they elect to seek care. And it's going to have a significant financial impact on practices, on hospitals, and certainly as consumerism grows, as patients speak and talk with their money, with their wallets, with their pocketbooks. So again, these are all, and this has a steamroll. If you choose not to participate in any programs, you will see, it's not just about the 4% cut from Medicare and the MIPS and Quality Payment Program. Referral streams will start to dry up. They will shift because everybody, the entire healthcare ecosystem, is going to be rewarded and paid on value over volume. It's not just Medicare providers. It's not just Medicaid. It's not just the commercial payers. We're actually outrunning the federal government right now in these types of programs. It's everybody. So anybody that participates in these programs, they're going to begin to want to work with doctors who understand it, and practices, and nurses who understand the strategy. And they want to be rewarded. Everybody wants to be in the same structure, because if you have high utilized services, those are expensive. And they may not be high quality. So then you got a double ding. You're a high utilizer and you don't have high quality. You could see, if you're in that category of the next 3 years, you could see a 30% reduction in your compensation from where it is today. So it's very important to understand how all these shifts affect you, affect your practice, affect your community. Everybody on the line today is taking the time to listen, which is great. And a lot of you are living and breathing this in your communities. This is not new, and this is happening. This has been happening fairly quickly over the last 3 or 4 years. But it's really going to pick up with the implementation of MACRA, with the whole MIPS program, the advanced APMs, the quality payment program in general. That's all beginning to steamroll. And again, it's not just Medicare. It's Medicaid, it's the private payers, it's the commercial payers. They're all evolving. So now what can you do? And what are the things, some of the high points to look at? It's important to focus on optimization, how you can really optimize your current infrastructure, how you provide care, how you implement and deploy innovation, how you use innovation to improve care, to improve your ROIs, to increase revenue, to improve outcomes, to become more efficient, and to really improve your economy at scale. And as you can hear a couple times now, it's not about doing more with more. It's about being more successful with probably less. Or doing more, being more successful with what you have today. And that's around optimizing what you have. And that's the crux of it all. And it's actually not that simple. It's not that difficult. I'm going to give you some simple solutions here. So again, look across your organization and your community for new revenue streams, new profit or additional profitability of current services. That's reevaluating contracts. That's getting and some of this could be foreign and some of this could be common sense for everybody. It all depends on their proficiency in business. But none of this is outside of just standard business metrics. What all of us, I've started numerous companies and led companies and helped companies build them. These are all just foundational business strategies but we're beginning to deploy them more in healthcare. And healthcare is shifting in this direction fairly rapidly as well. But some specific strategies, and I've already talked about optimizing your revenue cycle, looking at whatever new services based on your specialty that you might be able to offer, new devices that you might be able to offer. Importantly there, and it's something that we've done for our practices and our customers, is there might be a device that you want to purchase, but it's also very important to make sure the reimbursement, because the salesperson that's coming in to sell you a new device, maybe make you cutting edge, you've got to look at your reimbursement rates. Because they're going to give you an ROI or pro forma on it, but it very well may not match up. You have to be saying, hey, you can get $190 per procedure for this. When you actually pull your contract, it might be $98 or $68. As the salesperson is going to sell you on these great numbers, but if they have not looked at your contract to prove it, nothing that we go off and do for a lot of our customers, because we just want to make sure, again, we're dedicated to improving revenue and improving profitability for our customers, and that's a very important aspect. If you're going to buy a new device for $1 million, $2 million, or whatever it is, you've got to make sure your current and your future reimbursement streams support it, whether that's through insurance or if that's through private pay. But an important aspect to keep an eye on. Certainly, and there's a lot of great opportunities based on specialty to do that. But also, very important, foundational, fundamental to business in general. I don't care what sector you're in. Make it easy to conduct business with your organization. Align your processes, your services, and your innovation to ensure patients can easily schedule their appointments, they can easily pay for their bills, and they can be seen on a timely basis. So what I mean by all that, there are some real innovations, simple innovations, that are pennies on the dollar in the ROI, that patients can easily schedule. They shouldn't have to call and be put on hold and make this arduous telephone tree system to make an appointment. There's so many cheap innovations out there that they can go right on your website and easily schedule an appointment. It's integrated into your scheduling system. It takes the person out of the equation. Maybe it doesn't have to be for all appointments. It can be for just a subset of appointments. But I promise you, it's a great way to improve the relations with your practice, to increase and also increase visit volumes for certain visits that you want to have. I've been living and breathing this specific strategy for 7 years now. I promise you, it works tremendously. And also, when patients are seen, if they have to wait, if their appointment's at 11 a.m., and they have to wait more than 20 to 25 minutes, there's a direct correlation to unsatisfaction, lack of value for the appointment, and overall just unhappiness. It doesn't even matter if the doctor or the nurse provided this amazing quality of care and everything was fantastic past that. The psychology of having to wait in the waiting room consistently more than 25 minutes, and certainly it's really bad over 45 minutes, things happen once in a while. That's not an issue. But if you're constantly running 30 to 45 minutes behind, that you need to take corrective action. So you the workflow of your practice and look for some efficiencies or economies of scale. Because patient satisfaction is going to be 5 to 15% of revenue, or 5 to 15% of future revenue will be tied to patient satisfaction. That actually started in the hospital several years ago, and it's shifting very quickly into the physician practice, and it's certainly starting this year with MIPS and MACRA. How it affects patient satisfaction will affect your revenue stream. So you want to make sure that patients are seen on a timely basis, because again, patient satisfaction, quality of care, all of those components are very important to your future revenue streams. And also making payments. I already spoke about how it's important to collect a copay whenever possible when the patient presents themselves in the practice. Sometimes you can't, but make sure you get prior authorizations and that you're getting claims adjudicated properly. These are all components that are going to be very, and also on the patient pay, there's solutions that, again, pennies on the dollar on the ROI, that will help you collect your money using technology, making it simpler, sending out a simple, customized bill for the patients. It's easy for them to read, easy for them to understand what they owe, and easy for them to pay. I promise you, your collections will rise with that type of a strategy. So those are very simple things that every practice can deploy to And those are just basic best practices that we all deploy in healthcare or across our companies, no matter if you're in healthcare, transportation, education, construction, hospitality, those components, making it easy to conduct business with your organization. So now some efficiencies and economy of scale that I want to touch on. It's very important to understand and manage your cost structure. What do things cost your practice? You're going to be giving more transparency in this. To understand your costs. Medicare is publishing their rates, their costs. We're trying to get the commercial sector to do it more. But you've got to understand, before you can go at risk in a contract, you've got to understand what your costs are for that episode of care that you're going to negotiate. So understanding your cost structure, the best of your ability, you'll never get it to perfection, but you can certainly get to figure out you're in the ballpark that that specific episode or those specific episodes cost me $120 ballpark, or between $120 and $150, somewhere in there. But they're going to contract at $160 or $170. If you know you're in the 120, 140 range, you probably can go at risk at 160, 170. If you're confident that you're 120, 140. But if you're not, you certainly can't go at risk and take an episode price at 160 or 170 when it could cost you 210 or 220 or more. So just simple things, and again, that's kind of what we do and what's near and dear to our hearts. But everybody can begin moving in this direction. Streamlining operations and increasing throughput. I touched on that. I touched on that from the visit volume, on visit loads, on seeing patients on a timely basis. In looking at your cost of operations, I'm sure everybody's shaking their head. Yeah, it has increased 50% over the last 10 years. But your pay has not, I promise you. And so you must look to how can we get the cost of operations down. There's lots of strategies. That's one of the reasons why we exist and we work successfully with customers and practices in hospitals. It's because we look at the cost of operations, and you got to drive additional revenue, and you got to drive additional cash flow while stabilizing or reducing the cost of operations. Understanding one of the important aspects of here is understanding your current staffing model. Where can people be repurposed or refocused to improve productivity? Look at how and take on how healthcare is shifting, so wellness models, care coordination, and pop health activities. In a lot of those cases, those could be revenue generating. And that's some of the augmentation that we go in there and we help practices shift. And look at those revenue generating opportunities, new business lines, new business models that are being rewarded and paid for. And then just again, where can technology help you? Where can co-sourcing options help you? Reduce cost per case, leverage innovation internally and externally. It's not about buying more things. It's about optimizing what you currently have. Sometimes you may have to buy something if you don't have a well-tuned, or you have an EHR that can be customized to your workflow, customized to your specialty. You may have to purchase, but many do. And many have a great infrastructure and technology. It just needs to be customized and leveraged for them, for the way they practice medicine, for their specialty. And something, again, I love is deploying clinical, financial, and administrative best practices. It'll improve your bottom line, I promise, I guarantee it. So now so that's a lot of the strategy items. Now talking about value-based care and how to navigate some of those components, and also what to look for in your community. And again, I'm not going to spend a lot of time on MIPS and MACRA because we have other presentations. We've dove into them heavily in December. They're all posted. They're 1 hour, easy listens, and also all the slides are available as well. So, but on MACRA, MIPS, and alternative payment models, obviously it was rolled out. It was passed through Congress back in 2015, but we saw last October we had the final rule published. And essentially there are 4 options for care providers. Option 1, and I think about 68% of care providers today qualify for the mixed program. And again, I do highly recommend that you engage the program, because it's not just about the 4% increase or reduction that you could see. Certainly, if you qualify for the program, as I mentioned earlier on the top of the show here, everything in healthcare is evolving in this direction. Even with a new administration coming in, MACRA was passed with full bipartisan support. I don't even know the last time, and I've worked on Capitol Hill for about 16 years, and I've never seen a bipartisan bill as large as this, with this type of support on the Republican side, the Democratic side, the House side, and the Senate side, bipartisan and bicameral. So this is moving forward. This is the future of healthcare. This is inside the government and outside the government. So it's important to understand it, even if you don't qualify for it for one reason or the other. Very important to understand its effects on you and how you can engage it in some capacity. In most providers, certainly that will be in the top 2 categories. They can report on 1 quality measure, 1 improvement activity, either 4 or 5 advancing care information measures to avoid a negative payment adjustment. So it's very easy, very, very easy. And we have a very simple template that we work with practices on that allows them to, again, report just 1 quality measure or 1 improvement activity or a few advancing care information measures, and that avoids that 4% cut. So again, very simple. There's all this rigmarole and hand-wringing that was so terrible and so difficult for care providers. That was unsubstantiated and untrue. It's a very simple program if you engage it and take a few minutes to learn it, and even work with a company like ours to help you. That's option 1. Option 2 is, and that's over a 90-day period. You have to report those measures over a 90-day period. That's option 1. Option 2 is for a minimum of 90 days, 90 plus, and you have to submit a mixture of measures and activities data. That means your performance criteria could start anytime after January 1st this year. You can get a neutral or even a small increase. So say you want to report for 95 or 180 days, and you want to do a mixture of quality measures, improvement activities, maybe a couple of ACI measures, you might get 2 or 3% increase. So that's, I think that's pretty strong. And that's where probably a lot of practices are going to shoot for. But if you want to try to report for the full 365 days, you can certainly do that. I think that could be a lot to take on the first year. But, we have a new number of practices that are doing that today, that are already gearing up for option 3. So, and again, we'll get to all questions. My team in the background here, they're going to answer questions that come up when they can. But we'll also be opening up those questions for everybody here towards the end of the presentation. But again, option 1, very low bar, not to receive the 4% cut. But options 2 and 3 give you a chance to go for 1, 2, 3, or even a 4% increase, depending upon how much time you want to report on and how many activities and measures you want to go for. But again, a very simple plan, and I think, and this perfectly positions you for where healthcare is evolving. And also, starting probably in May, June, we're going to start to talk about 2018. So 2017 is a fairly easy year. Any of these options, certainly options 1, 2, and 3, are not that difficult with the right partner to be successful. But in 2018, the lift is going to be greater. So we do recommend people start this planning. We also recommend that you integrate it into your revenue cycle, because there's a lot of these components that can be built and help right inside your EHR. It's not about doing more, it's about being more strategic, optimizing what you currently have, optimizing how you provide care today. And that can all be done fairly simply. And option 4 is for some of the more advanced practices who have taken on the ACO structures or CPC structures or oncology tracks or other models from the Innovation Center, from CMS's Innovation Center. I'm not going to touch on a lot of that today because most of the people, or everybody on the call I think today is focused on the first 3 options. So I'm not going to spend much time on this graph. I think everybody has seen this graph in exhaustion. Again, all these slides are available. But in your first year on MIPS, you can get up to a 4% increase, or if you totally ignore the program and you qualify for it, you'll get a 4% cut. In year 2, you get the 5% increase. If you totally ignore the program, you'll get a 5% cut. In year 3, up to another 7% increase. Or if you choose to ignore, 7% cut. That's a lot of money over time here. In year 4, 9% increase, up to 9% increase, or a 9% cut if you qualify for the program and choose to ignore it. So, and again, the advanced APMs is a little bit different of a beast, but certainly very rewarding, and you're going to see some great evolutions. And we also see practices starting off in the MIPS track and then evolving probably year 2 or year 3 into the APM, the alternative payment model track, and taking even higher increases. That's what we're going to work on with our practices through. So great opportunity. Regarding MIPS for 2017, and this has actually been a lot of work over the last 10 years that me and some of my peers, a lot of my peers, have put forth. It's really integrating a lot of these programs, PQRS, meaningful use, value-based modifier, e-prescribing, other quality initiatives under CMS, integrating them all into one program, which is MIPS, or into the advanced APMs. But integrating them into one program, one track for care provider and practices to go down. They don't have all these different reporting initiatives. And I promise you, Tom Price is dedicated to that mission, to make sure we simplify reporting. We don't force care providers to have to do all these different reports for all these different programs to get incentives or be rewarded. They're all integrated into one. So for MIPS in 2017, quality will replace your PQRS. So if you've already been doing PQRS, you're very well positioned to have success with a quality category. And if you've done meaningful use, you're already well on your way to the ACI, the Advancing Care Information category. And the new category in 2017 for everybody is improvement activities. It's only low score, it's only 15% of your performance score year 1, but, and probably May, June, we're going to start talking to practices and hospitals about how this is going to increase. I don't know if it's going to go to 25% or 35% for 2018, but improvement activities is where the bar is really going to be increased. That's where CMS is going to leverage. And also starting in 2018 is the resource use and cost, and that replaces the value-based modifier. So we'll have 4 categories in 2018 to report on, with improvement activities being increased for sure. And again, you can go back to any of those presentations that we've done in December, and I walk through all of that in great detail. But that's really the MIPS program in a nutshell. We do work a lot with rural health clinics and F2HCs, so I want to talk about them a little bit. They are not subject, for the most part, there are some exclusions, but they are not subject to the adjustment, but they can voluntarily participate. And that kind of goes back to the strategy. We highly recommend that practices, F2HCs and RHCs, they look at it, they deploy strategies around this, because this is how healthcare is evolving. There's no reason to delay it. It could affect you in other ways strategically. So hopefully, and we're working a lot of them to implement these types of programs for MIPS. So it's just the right direction in general to integrate your revenue cycle around this. So I think it's very important, again, that all these slides and this content will be available, because I want to get through my presentation here and open up for some Q&A. On the MIPS side and the QPP, I think some important takeaways, because there was so much negativity, there was so much stress around it, saying how it's going to be the downfall of a small practice, it's going to be so difficult. That was all unfounded, that was untrue. So it's pick your pace, it's highly flexible. You can choose what objectives and measures that you want to participate in, that best fit your practice, best fit your specialty, best fit your workflow, much more customizable than PQRS and meaningful use and any other program that you probably ever participated in before. And there's a lot more money behind it. So I think pick your pace, highly flexible. It's not all or nothing like meaningful use. You can get partial credit, you can get bonuses available, you can easily avoid penalties and increase payments. So I think if you try for the extra 4% in 2017, you might get 2 or 3, 4%. So I mean, we would love to help you get on your way to getting a 2, 3, 4% increase In the following years, it's 5%, up to 5%, then up to 7%, then up to 9%. A lot of money. It's millions of dollars for practices, tens of millions of dollars in some cases. So, a great opportunity. A couple months ago, I published a 4-point plan for MACRA and MIPS success. You can, when you receive this presentation, you can click right on that link below. It's also, you can just go out there and it's in Becker's Hospital Review. It's a plan for all practices and hospitals that are deploying MACRA strategies and MIPS strategies. Very simple foundational strategy, a 4-point strategy. Also, something that we don't pay a lot of attention to in the industry, and my team is focused on it, is looking at, it's not just what CMS is doing, but every state has different initiatives to improve care quality, to reward improving care quality, to navigate value-based care, to get payment structures under patient-centered medical home or other value-based medicine systems and models. So here's just a couple of examples. New York, Georgia, PCMH is fairly proficient across all 50 states at this point. So if you're in a multi-specialty group or a primary care group looking into a patient-centered medical home, there's a lot of revenue there. And we have the expertise. If you need any help with that, just let us know. But New York, Georgia, Kentucky, Florida, they all have different types of programs. And a lot of them are similar. They are different because they're in different states and they're state-based. But a lot of the tenets, a lot of the quality reporting is similar. There's a lot of money to be made. And if you're doing PCMH, you're very well positioned to have a great success run with MIPS and vice versa. And again, any question you guys ever have on this, please let us know. So time to begin to wrap this up and then open up for some Q&A. What will it take to succeed financially? Very important, as I touched on this at the top of the show, pay very close attention to the bottom line. Look at revenue, look at cash flow, look at patient visit volumes, look at your profitability. You know, we make claims, if we work with you, we increase your profit, your revenue, cash flow, and hopefully profitability by 5, 10, 15%. Because you're deploying best practices, we're creating efficiencies, we're creating economies of scale, we're leveraging innovation. It's very important that you keep a close eye on this, because you don't want to turn your head one day and notice that you're off. On average, when we look at a specialty, it doesn't matter what community you're in across the country, but now we're working in all of them, and we run some numbers across all of them for normalization. We can make a guarantee of additional 5 to 15% because, I mean, we look at gastro doctors in Southern California at average billing at $85, $95 a claim. They should be at $130, $140 a claim. Or cardiologists at $120, they should be at $170 a claim or $160 a claim. I can do this for all specialties. People are off. They're not billing well. They're not capturing the revenue. They're not appealing the denials. The revenue cycle is nowhere near as strong as it should be. That's why we can make these strong claims of increasing revenue, improving profitability. But you got to pay close attention to the nuts and bolts. We talked about a lot of this, but optimize your coding and make sure you're comprehensively coding. You're capturing the right code for the right episode. ICD-10 changed a lot. There's so many practices and specialties that are not billing appropriately right now and not getting paid their full due. Claim creation, you're scrubbing and submitting the right claims, clean claims the first time. Denial management, appealing 100% of denials. On average, only 67% of denials are appealed. You should be appealing 100% and then going after root cause analysis to make sure that you don't making the same errors, or if the payer is constantly denying, find out why. Let's go in there and let's go to the root cause of that, and we'll fix that so we don't get those denials anymore. That's tens of thousands of dollars per practice that we work with of additional revenue, and obviously improved cash flow. Just that one aspect is anywhere from $10,000 to $50,000 a month. Eligibility verification, prior authorization management. Very important to ensure that you're going to get paid for the procedure and that you have the right authorization. Chasing it down afterwards can be a little bit hairy. Certainly needs to be done, but let's try to do it on the front end. Get prior auth done. Eligibility verified. before the appointments, before the procedures. And audit and look at those payer contracts every 6 months. That's the best practice that we deploy with our customers. We make sure that practices are getting paid and hospitals are getting paid for their claims, for their contracts. 34% are not. It's a lot of money. We have one hospital customer that just managing, playing the game with the payers, managing the contract for an extra $9 million a year. 150% increase by playing the game with the payers, by recredentialing the doctors every single month. That's what the payers do. They're taking them off the panels every single month, and we go recredential them every single month. We caught on to what they're doing, and we played their game. $9 million. So that's why we got to pay very close attention to credentialing, to contracts, variance rates, and set up KPIs across your revenue cycle. So as a CFO, as a billing director, billing manager, I don't care if you're a one doctor practice up to a 700-bed hospital, because we manage all of those sites. You want to have the right dashboards in place so you can manage your money. It's your money. Everybody in your practice is working, and your hospital is working hard for it. Keep it and know what's owed to you. On the clinical side, begin the transition from volume to value. It's the heart of every single payment model coming out. So you got to make sure you're integrating data from clinical and financial sources. If you have a 5 or 6, 10 doctor, physician practice, you might be able to get away with that in your own one system. You might have one of the top 10, 15 EHRs out there, which is terrific. The ClinicWorks does a very good job with that. There's several others. My old company, Greenway. There's other ones. However, if you've got a larger community, or you've got a health system, you might have to pull in data from clinical and financial sources, and maybe administrative sources, and analyze that. Have data visualization strategies, but it's critically important for moving forward, because that's all you're going to be paid off of, all that information, and showing success with that information. I mentioned this earlier, but make sure your EHR are customized to your workflow, to your specialty, to your procedures, that they're capturing the right codes, they're using the right codes. That documentation is driving your calculations for MIPS and meaningful use, and any other programs you may participate in. This is all can be done. Taking on MIPS and alternative payment models, or these new payment models coming out, is not about doing more work, more complex work. It's more, I mentioned this a couple times, optimize the health IT that you've already invested in. It can be done. Make sure your dashboards are capturing and monitoring all of these measures, clinically as well as financially, as I've already mentioned. We want to implement best practices wherever possible. Here's an example. For our MIPS customers that we're monitoring and we're helping, we'll go in there and we'll put out their entire MIPS track, customize their EHR to their program, to whatever initiatives and measures they want to calculate and capture. And we'll give you best practices to work from and suggestions to work from. And then we'll go in every 2 weeks remotely and just monitor and make sure that you're putting the right things, you're using the EHR as we set it up. And sometimes we'll do it monthly, sometimes we'll do it every 2 weeks, and sometimes we'll do it quarterly, depending upon how we want to work together. But that's a best practice, not looking at it 3 days before you got a report. And you're going, oh my gosh, this is not right, I'm going to fail here, I'm not going to get my maximum incentive. Or in meaningful use, it's worse. Because it's a pass-fail, it's not, there's no variance. And so is PQRS. So we want to set those best practices. Also, a monthly scorecard. How are we doing? How are you doing? How are we doing? Whoever is supporting you. And in this, scorecards, I like the strategy where companies now work, they go at risk. I'm sick of people selling and charging practices and hospitals for all this stuff up front. Our model is, we go at risk with you. We don't charge you anything. When you make money, we make money. And we don't make any money until you make money. That's how this industry should begin to shift. I've been saying that for many years now. And finally, that was a strategy that we deployed here at iHealth. But set up the scorecards so you hold your vendors accountable to your success. And hopefully you can change their contract with them so they're compensated when you're compensated. When you achieve success, they will get paid. And care coordination across the care continuum is the only way you're really going to be able to optimize outcomes. And so it's very important to ensure that you begin looking at that and deploying strategies where necessary. You may not have a care coordination strategy right now, but if you're implementing a patient in a medical home, or if you're setting up interoperability with other practices, you're sharing data, it's all care coordination. And I promise you probably are, you just don't realize it. But if you've got 6 providers and that patient presents themselves and the regular provider is not there, the provider, that's care coordination, where someone else will tap into the database and see the patient, whether it's a nurse or a doctor. That's all care coordination. We've got to make sure they're working together to improve outcomes. That's how we're all going to make more money. And as I mentioned at the top of the hour, I only brushed on it, but it's very important to improve patient engagement, to support patient engagement, patient education, and patient empowerment. We've got to empower our patients. We've got to make sure that they're using technology, that we've deployed technology for them to use, and encourage them to use it. They will make your job easier, I promise. It's also how the entire healthcare system is shifting, so to make sure you're there. I know I'm running low on time, so if you've ever heard me speak before, I personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. There's more money flooding into healthcare than ever before. That's not changing. That's not going to change. But you got to make sure that you're strategically positioned and aligned to capture your piece of the pie. Here are some additional resources. The qpp.cms.gov website will help you a lot with some of the basic metrics. It doesn't have to be the strategies, that's what we kind of do, but if you want to see at a high level some of the metrics and measures for your specialty, it's a great website. Obviously, our website for a lot of in-depth strategy and best practice and knowledge. You can check out iHealth. CMS is a great site, innovation.cms.gov. And they talk about a lot of state-based programs, state-based innovation, new care models that are available to you in your community, but then also what's available from the federal government. And as mentioned before, Medicare Physician Compare, the website that will highlight many, if not all, Medicare care providers. And they begin scoring and ranking them. So go take a peek out there. See what they say about your practice and about you individually. So, Alex, I'd like to turn this back over to you. If we have any questions that you haven't answered or anything open, please feel free.
Thank you, Justin. We received several questions. Let's go ahead and dive in. Our first question asks, what role do you expect consumerism to play on future value-based models? Specifically, to what extent will it impact our revenue?
Yeah, I touched on that a little bit during this discussion. And to be honest, it's going to be 5 and up to 15%, depending upon the model of care that you engage. And that's just a direct influence from what CMS or a payer may hold back or add an incentive to you. Never mind where patients start to have more choice to seek care based on what something costs, not just because they have a relationship with you. They might love you today and think that you're terrific. But if you cost an extra $2,000 a year, a lot of patients can't afford that. They don't have a choice. They may love you. They may have been your patient for the last 15 years. But as healthcare's costs are shifting, panels are changing. Obviously, we know that ACA is going to be changing. It's going to affect care, when patients seek care, how they seek care, where they seek care, and when they seek care. I hope that helps a little, Alex.
Thanks. Our next question says, do you think MIPS will require a full year of reporting for 2018, or will they have flexible options like 90-day reporting?
My gut is, I sit with CMS now almost on a weekly basis, and even now, even a new administration coming in, I believe you're going to see flexibility in 2018. It may not be as flexible as 90 days, but it might be 180. I think that you'll get an additional added incentive for the full 365 days, but I believe you're going to see flexible reporting. They're going to increase improvement activities, obviously add on the value-based modifier and the resource use cost in 2018. but I believe that you're going to still have more flexibility in 2018.
Great. We'll ask one more question. Our practice will likely report for the MIPS test option for 2017. Which measures are easiest to avoid the negative penalty?
I would say the ones that you've already been doing. To be honest, if you've already taken, if you already participated in PQRS or in meaningful use, those are aspects that probably are fairly simple to start with. Start with what you know. But if you have any additional questions, exactly what my team does, we'll try to help you in every way. But that's kind of where I would start with that.
Great. Well, thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar, Best Practices and Strategies to Successfully Navigate Healthcare. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours. We will also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenter, thank you for joining us today and have a great rest of your day.
Yes, thanks everyone, and we do look forward to your thoughts in the questionnaire and in the comments. Any comments you have, we'd appreciate knowing. Thanks so much.